Hi guys, I'm Zorik Manali, final year medical student, and today we are going to discuss about diabetic neuropathy. Diabetic neuropathy is one of the commonest complications of diabetes. It affects all the types of the nerves. First, you should know that there are a lot of causes of peripheral neuropathy. There are infectious causes, metabolic causes, endocrinal causes, a lot of causes. So one of the causes in endocrinal section is diabetes mellitus, and it is one of the most common causes. There are organic causes like alcohol abuse, inorganic causes like lead poisoning, lead arsenic poisoning. So there are a hell lot of causes of neuropathy. So we are discussing one of them today, that is diabetic neuropathy, and it is one of the commonest causes of neuropathy, and even one of the commonest and complication of diabetes is neuropathy. It affects all the types of the nerves, the peripheral nerves, the central nerves, all types of nerves. Talking about pathogenesis, what happens here is the blood supply of nerve, that is vasa nervosa, is affected. So because of the affection in the blood supply of the nerve, there is reduced blood flow to the nerves, which will result into damaged nerve, thus resulting into sensory loss and damage to the limbs. There are other theories about pathogenesis of diabetic neuropathy. One of them is excessive vitamin loss. In diabetes, there is polyuria, that is, the person who have diabetes have frequent urinations. This, and when the person is urinating frequently, the person will lose a lot of vitamins. So there is polyuria that will result into hypovitaminosis. And another pathology is in DKA, that is diabetic ketoacidosis. The ketone bodies affect directly to the axon of the nerve, resulting into axonal degeneration. Another pathogenesis of diabetic neuropathy is the sorbitol, accumulation of sorbitol in the nerve cells. This is also known as polyol pathway. What happens here is the cell, there is accumulation of sorbitol inside the cell due to some specific pathology that converts glucose into sorbitol by the enzyme known as sorbitol dehydrogenase. Here we have glucose, excess glucose, and this enzyme sorbitol dehydrogenase converts it into sorbitol. Thus the sorbitol, it doesn't go out of the cell and pulls a lot of water inside. Thus there is osmotic swelling. And This will result into the damage of the cells. Let's move forward. Let's go into classification. Neuropathy is classified into somatic and autonomic classification. Somatic is further divided into polyneuropathy and mononeuropathy. Polyneuropathy is affection of hell lot of nerves in both the limbs of the body. Mononeuropathy is affection of one or more nerves in one limb of the body. Polyneuropathy can be symmetrical or asymmetrical. The typical clinical picture of symmetrical polyneuropathy is glove and stocking sensory loss. Glove and stocking sensory loss. The distal part of the upper limb and the lower limb is affected. The sensory function is affected. So, symmetrical polyneuropathy is mainly sensory and distal. There is diminished vibration sense distally. There is glove and stocking loss of superficial sensation. There is loss of tendon reflex in the lower limb. There is pain in the lower limb. There is burning sensation in the sole of the feet. And there is abnormal gait, and it is especially void based. The second type of polyneuropathy is asymmetrical polyneuropathy. It is also known as diabetic amyotrophic. In this case, what happens is just one of the limb is affected. The affected limb, there is weakness and wasting of the proximal muscles, especially lower limb. In asymmetrical polyneuropathy, you can see the wasting and the weakness. There will be severe pain, and due to the severe pain, there will be cachexia, which is also known as neuropathic cachexia. And there is absent tendon reflex on the affected side. So there is polyneuropathy symmetrical and polyneuropathy asymmetrical. In polyneuropathy symmetrical, we have glove and stocking sensory loss. The sensory system is mainly affected in the distal part of the limb, and there is burning sensation in the feet, and you have void based gait. In polyneuropathy asymmetrical, just one of the limb is affected, especially lower limb, and in the proximal part there is weakness and wasting of proximal muscles due to pain. There can be neuropathic cachexia. There can be hyperthesia or paresthesia, that is exaggerated sensations or distorted sensation, and there is presence of absent tendon reflex on the affected side. Mononeuropathy. Mononeuropathy is mostly affection of one or more nerves in certain region or portion of the limb or the body. Motor or sensory function affected within a single peripheral or cranial nerve is known as mononeuropathy. If it affects the third, fourth, and sixth cranial nerves that supplies the muscles of the eye, it can result into diplopia, that is double vision due to the squint and stuff. It can affect femoral and sciatic nerve. There can be median nerve compression. What happens in diabetic neuropathy is there is glycoxylation. Due to glycoxylation, there is thickening of the median nerve due to glycoxylation. Not only the median nerve, even the lateral popliteal nerve is thickened. So any nerve that is into a compartment, when a nerve is thickened, there is greater chances of getting it compressed. So there is median nerve compression causing carpal tunnel syndrome. There can be foot drop due to lateral popliteal nerve compressed. This is the picture of the drop foot. A patient comes to a clinic complaining of abdominal pain. You should also always keep in mind that the patient can be complaining of abdominal pain due to truncal radiculopathy. It can be rare. It is rare, but you should always keep this in mind to result into abdominal pain. Now let's discuss about autonomic neuropathy. The autonomic nervous system of the human body supplies the smooth muscles, cardiac muscles, smooth muscles of the GIT, the smooth muscle on the urinary bladder, the smooth muscles on the blood vessels, the smooth muscles on the sex organs. It also supplies the sweat glands and the bronchial smooth muscles. So, when autonomic nervous system is affected, the functions sympathetic or parasympathetic function of the human body can be affected. Sympathetic is for flight and fear response, flight, fear and fight response. Parasympathetic is moreover a relaxed response. So the organs that are supplied by autonomic nervous system is affected. Let's start with the heart. What happens is the function of the heart is distorted, resulting into exercise intolerance. After doing some exercise, the person will feel severe fatigue and pain. The person will experience orthostatic hypotension. When a person changes its position from sitting or sleeping position to the position of standing up, the blood is pulled to the lower part of the body. When blood is pulled to the lower part of the body, the sympathetic nervous system works to maintain the blood pressure so that the supply to the brain is not reduced. So in this case, the sympathetic nervous system is affected, and when a person wakes up from the sleep, or when the person stands up from sitting down position, the person will feel dizziness or the person will feel syncope. Digestion. What happens in digestion is the whole GIT gets atonic. There is esophageal atonia. The tone of the smooth muscles of the GIT is destroyed. There is decreased bowel movement, and there is decreased colonic movement, resulting into constipation. Along with this, what can happen is the parasympathetic can be exaggerated and can result into diarrhea. The diarrhea is especially nocturnal, alternating with constipations. In urinary tract, the smooth muscles, the detrusor muscles, cannot contract strongly the way it should contract. So there will be urinary retention. Along with this, there will be urinary incontinence. The patient will not able to hold the urine. In sex organs, the patient can have erectile dysfunction due to the effects in the vascular smooth muscles, and the female patient can have vaginal dryness. Talking about the glands, the function of autonomic nervous system related to gland is known as pseudomotor nervous system. Pseudomotor function. The pseudomotor function, if affected, it can result into increase in function or decrease in function. The increase in function will result into excessive sweating. The decreasing function will result into less sweating, or you can say it's anhidrosis. And there can be, and there is increasing function, it can also hyperhidrosis. So the hell lot of things happen when autonomic nervous system is affected. The patient wakes up in the morning. He wants to get out from the bed and stand up, but the patient can't. He falls down. The patient can't eat his food properly because he has abdominal problems. There is constipation, there is esophageal atonia, there is abdominal pain, all lot of things. The patient can't do his exercises well. There is exercise intolerance. The patient doesn't have good sexual functions, and the patient doesn't have good urinary function too. So the life of the patient is damaged. So, as I already said, we have exercise intolerance and orthostatic hypotension in CVS. We can give ACE inhibitor and beta blockers for exercise intolerance and help to reduce the workload of the heart. For orthostatic hypotension, we can give midodrine or clomidine. They can help in compensating the blood pressure. We have in gastrointestinal case, we have gastroparesis. Gastroparesis is delayed gastric emptying in spite of any mechanical obstruction. Because of the reduced tone of the GIT muscles, there is delayed gastric emptying in case of autonomic neuropathy. So we give metoclopramide for this case, which increases the movement of the muscles in the stomach, the intestine. Metoclopramide is a dopamine agonist. We have a lot of things like abdominal pain, nausea, vomiting, bloating. You can give antacids for it. You have constipation, which can be treated by laxatives. So a lot of things are happening here. You have erectile dysfunction, you can give sildenafil. For vaginal drainage, you can give some lubricants. For urinary incontinence and retention, you can give bethanacol, which will squeeze the detrusor muscles of the urinary bladder and help in urinary outflow. We have sweating, we have anhidrosis, heat intolerance, dry skin, hyperhidrosis. For dry skin and stuff, we can give skin lubricants, and for excessive sweating and stuff, we can give scopolamine and glycopyrrolate, which will decrease the sweating. So this is all about autonomic neuropathy. There is affection in the autonomic function of the body. The cardiac function is affected, the GID function is affected, there is sexual dysfunction, there is blood dysfunction and pseudomotor dysfunction. So we treat them. So how do you diagnose diabetic neuropathy? First, we should diagnose diabetes to diagnose diabetic neuropathy. It is almost always followed by diagnosis of diabetes. It is based on the symptoms and signs, the clinical picture that we studied before. After exclusion of all other peripheral neuropathies, we should always exclude other peripheral neuropathies by investigations like nerve stimulation, velocity test, electromyography. We can even do biopsy, but in very rare cases. Let's move forward to management. First is we diagnose the diabetic neuropathy, and the main focus here is two things. Number one is glycemic control, and number two is pain management. The glycemic control is very essential for the manifestation of somatic manifestations like polyneuropathy and mononeuropathy, but less fruitful for autonomic neuropathy. The patient of autonomic neuropathy most of them will die in the course of 10 years, and the glycemic control, according to studies, is not very much beneficial. But we should focus on glycemic control, the first important point. The second thing is pain management by all these drugs, tricyclic drugs, anticonvulsant drug, and opioid-like drugs. They are all useful for neuropathic pain management. Furthermore, we can consider the referral for the pain management. So we should just remember two things for the management, that is glycemic control and pain management. Thank you. This is all about diabetic neuropathy. I hope you get it. So we have diabetic neuropathy. There is affection in all sort of nerves. We have somatic and autonomic type of diabetic neuropathy. Somatic we have poly and mononeuropathy. Poly we have symmetrical and asymmetrical. Symmetrical we have globe and stopping sensory loss. Mononeuropathy we have diplopia, median compression and foot compression and foot drop. In autonomic neuropathy we have all sorts of manifestations, from cardiac manifestations, GIT manifestations, gastroparesis, sexual dysfunction, erectile dysfunction, urinary retention, all these things. And in management, the diagnosis is by exclusion, and for management we have glycemic control and pain management. Thank you.